10 years ago, after applying all my surgical skills and knowledge to the conundrum of TMD, and because of the less than predictable results, I decided that I could not, in good conscience, recommend surgery as the solution for the enigma. I had a burgeoning practice of patients, mostly females, showing up at my door requesting help, but I would now have to turn them away. Because of my broad background in the sciences and independent research, I decided instead to create my own study and ignore the myriad of congresses, textbooks, lectures, articles, and recommendations of colleagues from the many disciplines involved with the TMJ. I decided to instead apply the guiding light of my career. If one cannot find a solution to a problem, he is either asking the wrong questions or asking the wrong people, or both. So began a study by collecting data from the actual source with a very simple process. I began sitting with my patients and asking them and encouraging them to tell me everything they could about their symptoms, their history, and their problem with TMD. Many of them, at least half of the cohort, which was 12 out of 24, many of them repeated a similar comment. If I place a pencil eraser, my tongue, my finger between my front teeth and gently bite down, it feels better. After hearing this multiple times, the light bulb ignited, and I thought, I wonder what will happen if I make a device that fits between the front teeth and that it can be worn for 24/7. I constructed such a device and gave it to one of these patients who had symptoms for 20 years, asking her to keep it in her mouth 24/7, taking it out only to eat, and return in 3 weeks. 3 weeks later, much to my surprise, she said her symptoms were all gone. Then I applied this strategy to another patient and another and another. Not everyone had 100% of their symptoms subside after 3 weeks, but everyone had substantial improvement and continued to improve over time to the point of wearing the device limited to nighttime only. After treating 30 or 40 patients in this manner, I knew the anterior occlusion, disoccluding the posterior teeth, was effective, but I had no idea how it worked. None. What were the anatomic, physiologic, pathologic, neurologic mechanisms at play that allowed a simple device that only occluded the anterior teeth and disoccluded the posterior teeth to have such a profound effect on relieving the symptoms of TMD in patients who had suffered symptoms for 10, 20, or 30 years?